Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 397 of our pharmacotherapy series, which majors in upper gastrointestinal disorders. This clinical case discusses patient PRL from part 396 of this pharmacotherapy series. PRL is prescribed a 14-day proton pump inhibitor-based 3-drug eradication regimen containing amoxicillin and clarithromycin. So my first question to you reads, what instructions would you provide PRL regarding his medications? PRL should be informed of the importance of taking his medications as prescribed to minimize treatment failure and the development of antibiotic resistance. He should be advised that the proton pump inhibitor is an integral part of the 3-drug regimen and should be taken twice daily 30 to 60 minutes before breakfast and dinner along with amoxicillin and clarithromycin. PRL should also be informed of the most common side effects associated with his treatment regimen. All antibiotics included in the Helicobacter pylori eradication regimens are usually associated with mild side effects including nausea, abdominal pain, and diarrhea. Clostridioides difficile-associated diarrhea, a serious antibiotic-related complication, occurs occasionally. Oral thrush and vaginal candidiasis, in women, may also occur. Clarithromycin and metronidazole may cause taste disturbances. PRL, as well as all other patients receiving Helicobacter pylori eradication therapy, should be advised of the risk for clinically important drug-drug interactions that may occur with the medications included in their eradication regimen. Special attention should be given to metronidazole and clarithromycin, inhibitors of CYP3A4, as well as to substrates of CYP2C9, which is inhibited by metronidazole. Drug-drug interactions may also occur with histamine H2 receptor antagonists and proton pump inhibitors. The next question reads, what would have been the preferred initial Helicobacter pylori eradication regimen if PRL had a documented allergy to penicillin? There are two first-line treatment options if PRL had a documented allergy to penicillin. Metronidazole can be substituted for amoxicillin in the proton pump inhibitor-based 3-drug regimen, because similar eradication rates are achieved. Bismuth-based quadruple therapy may also be used, because it provides similar eradication rates to the proton pump inhibitor-based 3-drug regimens. If PRL's medications included metronidazole, tetracycline, or a bismuth salt, he should be provided additional information on these medications. Metronidazole-containing regimens increase the frequency of side effects, especially when the dose is greater than 1 gram per day, and may be associated with a disulfiram-like reaction in patients who consume alcohol. Tetracycline may cause photosensitivity and should not be used in children because it may cause tooth discoloration. Bismuth salts may cause darkening of the tongue and stool. Regimens that substitute levofloxacin for amoxicillin in proton pump inhibitor triple therapy have been used with success, but there are fewer studies to supporting their efficacy. The most common sequential therapy contains amoxicillin and, therefore, is not suitable for a penicillin-allergic patient. The next question reads, what drug substitutions are acceptable in the standard proton pump inhibitor-based 3-drug and bismuth-based 4-drug eradication regimens? There are insufficient data to support the substitution of ampicillin for amoxicillin, doxycycline for tetracycline, and azithromycin or erythromycin for clarithromycin. Substitution of clarithromycin 250 to 500 mg 4 times a day for tetracycline in the bismuth-based 4-drug regimen yields similar results, but substitution of amoxicillin for tetracycline lowers the eradication rate and is not recommended. The next question reads, what are the most important predictors of Helicobacter pylori treatment outcomes, and how may they alter PRL's response to treatment? The two most important factors in predicting Helicobacter pylori treatment outcomes are antibiotic resistance and medication adherence. Antibiotic resistance rates are highly variable throughout the United States and the world and thus are difficult to compare. However, there is evidence that clarithromycin resistance is increasing in North America and Europe and is thought to be the most important reason for the decreasing efficacy of clarithromycin-containing eradication regimens. Because treatment with clarithromycin may increase the likelihood of Helicobacter pylori resistance, clinicians should ask about previous macrolide use when deciding upon an eradication regimen. The clinical importance of metronidazole resistance is unclear, because higher metronidazole doses and the synergistic effect of combining metronidazole with other antibiotics appear to render resistance to metronidazole more relative. Resistance to amoxicillin and tetracycline is uncommon. Levofloxacin is emerging as a component of eradication therapy, but there are recent reports of increasing resistance to fluoroquinolones. Medication adherence decreases with multiple medications, increased frequency of administration, increased duration of treatment, intolerable adverse effects, and costly drug regimens. Although most eradication studies report greater than 95% adherence to medications, this high rate must be questioned because it is very difficult to accurately assess the level of compliance in clinical trials where patients take their own medications. Additionally, Medication adherence is usually more problematic in clinical practice. A longer treatment duration may contribute to non-adherence, but missed doses in a shorter regimen may also lead to failed eradication. Most bismuth-based 4-drug regimens require the patient to take medications 4 times a day and as many as 18 tablets or capsules per day. The complexity of this regimen as well as a mid-treatment change in medications with sequential therapy should be considered when selecting an eradication regimen. Although mild side effects are common with all of the eradication regimens, some patients will experience clinically important effects that lead to discontinuation of a specific drug or of the entire regimen. Other factors that may contribute to treatment failure include the high bacterial load, the specific Helicobacter pylori strain, e.g., CAG, a low intragastric pH, and genetic polymorphism, e.g., CYP2C19 polymorphism, when proton pump inhibitors are used as part of the eradication regimen. There are limited data to suggest that smoking, alcohol consumption, and diet may negatively affect eradication. The next question reads, what parameters should be monitored to determine PRL's response to treatment? Post-treatment testing to confirm eradication is recommended for patients with a Helicobacter pylori-related ulcer, persistent dyspeptic symptoms, malt lymphoma, or early gastric cancer. However, post-treatment testing is neither practical nor cost-effective for all patients with a Helicobacter pylori-positive peptic ulcer. When endoscopy follow-up is not necessary, the urea breath test is the preferred test to confirm eradication of Helicobacter pylori. To avoid confusing bacterial suppression with eradication, the urea breath test must be delayed at least 4 weeks after the completion of treatment. The term eradication or cure is used when post-treatment tests conducted 4 weeks after the end of treatment do not detect the organism. Antibody tests should be avoided post-treatment, because antibody titers remain elevated for a long period of time, up to 1 year, before they return to the uninfected range after successful eradication. If performed post-treatment, only a negative test is considered to be reliable. Upper endoscopy should only be used to confirm eradication and ulcer healing if indicated, e.g., severe or frequent recurrent symptoms, current or previous ulcer complication, because the procedure is costly and invasive. When endoscopic follow-up is necessary, testing to prove eradication includes a biopsy for the rapid urine test and histology. Ulcer healing can also be confirmed at that time. In clinical practice, the need for confirmation of ulcer healing and eradication in light of the declining success with the most commonly recommended eradication regimens must be weighed against the need, feasibility, availability, and cost of tests and procedures. Although post-treatment testing to confirm Helicobacter pylori eradication is recommended, patients like PRL, who present with an uncomplicated Helicobacter pylori-positive ulcer, are usually monitored for symptomatic recurrence 1 to 2 weeks after completion of drug therapy. The absence of symptoms is considered a surrogate marker for successful ulcer healing and eradication. The persistence, or recurrence, of symptoms within 2 weeks after the end of treatment suggests failure of ulcer healing or eradication or an alternative diagnosis such as gastroesophageal reflux disease. The next question reads, What other drug regimens can be used if PRL fails initial eradication therapy with a proton pump inhibitor amoxicillin clarithromycin regimen? What regimens can be used when secondary treatment fails? All initial eradication regimens require that there be an effective second-line treatment. Eradicating Helicobacter pylori is more difficult after initial treatment fails, and attempts to eradicate the organism are extremely variable. Second-line regimens should A. Avoid using antibiotics that were used during initial therapy. B. Use antibiotics that have less problems with resistance. C. Use drugs that have a topical effect, e.g., bismuth. And D. Use a 10 to 14 day treatment duration. If PRL was not successfully eradicated initially with the proton pump inhibitor amoxicillin clarithromycin, he should receive second-line therapy with bismuth subsalicylate, metronidazole, tetracycline, and a proton pump inhibitor for 10 to 14 days. Bismuth-based regimens are the most frequently used second-line treatments in the United States when standard proton pump inhibitor-based 3-drug regimens fail. A number of alternatives have been evaluated in small studies utilizing fluoroquinolone, rifabutin, an antibiotic used to treat tuberculosis, or furazolidone, no longer marketed in the United States. The results from the levofloxacin-based clinical trials look promising and suggest that these regimens may be an alternative to second-line bismuth quadruple therapy, especially for patients who have no prior use of a fluoroquinolone. However, increasing fluoroquinolone resistance, which appears to be easily acquired, is of concern and may limit the use of these agents for Helicobacter pylori eradication. Various rifabutin-based regimens are effective in treating patients with Helicobacter pylori strains resistant to clarithromycin or metronidazole. Regimens that include rifabutin should be the last option and only used for patients with multiple eradication failures because the drug is very expensive, and there are concerns about major hematologic side effects and the possibility of resistance. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 398.